episode of Talking Teen Treatment. My name is Pat D'Amico. I'm the CMO at Muirwood Adolescent and Family Services. Muirwood is a 10-year-old, highly regarded teen treatment program that addresses substance use and mental health disorders. You can read all about Muirwood and our programs on our website at muirwoodteen.com. I'm joined today by Jessica Mahn.
Yes.
Jess is a licensed marriage and family therapist and the clinical director at our girls' primary mental health program in Penngrove, California. She's also fresh off a raving reviews of a presentation that she did at the Adolescent Young Adult Collective in Malibu last month on teen suicidality. So we've asked Jess to join us today on this inaugural podcast to talk about how we talk about and treat suicidality in teens, and that should be exciting. But thanks for joining us today, Jess, especially today on the 4th of July.
You're welcome.
When the rest of the world is out eating hot dogs. But in this business, treatment providers never get a vacation. So thank you so much. So let's start with the great big picture. What do you think is driving, the elevated rates of suicidality that we're seeing in teens coming into treatment at Muirwood, and also not only what's driving it for most teens, but also talk a little bit about the LGBTQ plus community, where we're seeing, 400% incidences of suicidality among that population.
Yeah, I mean, when I was asked to do or present at the collective, sorry, I'm like trying to figure out my AirPods. When I was asked to speak at the collective, Brian Bowen was like, okay, so what is like the pressing thing that we're seeing in our communities? What would you like to speak on? And like, I came up with the thought right away, because we are the people that treat suicidality. You go to hospitals, you get placed on hold, then you go into treatment with us. So it is really common right now. I would say what the biggest thing that is kind of impacting the teens today is social media, TikTok, Instagram, Snapchat, all those things intended to be for various reasons are actually kind of what drives teenagers to really compare themselves, judge themselves, get cyberbullied, feel included, feel excluded, feel alone. And it's a dangerous world out there in the internet. And I definitely think that has impacted it. And COVID. I mean, everyone hates to say it, but COVID in the last however many years, 3-4 years, has increased the feelings of isolation and loneliness and hopelessness exponentially. And we did the best we could with COVID. It was all kind of thrown at us and, as a world, as a society. And the teenagers just didn't know what to expect.
Well, that's interesting. A very well-known clinician whose name escapes me once said that the opposite of addiction is not sobriety, it's community. Mm-hmm. So I think you're dead on that the isolation that the pandemic created, particularly in social settings where kids, they were gone from their friends and they missed, milestone events, mm-hmm. whether it be, dances and graduations and whatnot. It seems like it's going to be with us for a while. Would you agree?
Yeah, I definitely agree. And to tie it with the internet and social media, when we were in the pandemic, like in the thick of it, and we were in isolation, the only way we had to connect with people was through social media and FaceTime and text message. And so mm-hmm. those people that just didn't have the friends or maybe didn't have the courage to reach out to people online were even more isolated. It was really hard.
Yeah. The title of your presentation at IAC was I want to die. And I personally found that very interesting because, if you look at the definition of a suicide attempt, it's defined as a potentially self-injurious behavior associated with expressed or implied intent to die. So, and I'm sure you chose that title intentionally. No
Yes.
pun. So how do we get at in treatment? How do we get at that intent? How do we and not to trivialize this, but how do we how are we able to kind of categorize a teen as someone who's seeking attention versus someone who has the intent to hurt themselves or even worse? How do we get at that intent?
I mean, I think that's a really good question. And I would say in treatment, at least, it's all clinically relevant, whether they're doing it because they have a true intent or whether they're doing it to seek attention. Both are clinically appropriate. Because if it's for attention, you want to know why to the extreme that they're going. Is that their like desire? And what are they not getting at home or with their friends that's making them have to threaten their own life in order to get that attention? If they really do have the intent, then you treat it as that as well. So I initially approach it all the same, because whether their intent is there or not, the thought is there. And the scary part is if they are doing it for attention, excuse me, and we don't believe them, teenagers are creative. What if they take it to the next level and say, like, yeah, actually, let me prove to you how much I really want to do this. There's always an underlying message being said, whether it's true intent or for attention. And as we as clinicians have a responsibility to those individuals to take them at their word and do the best that we can.
We certainly don't have the luxury of making that call and taking that risk. So looking at every expression of suicidality as in the worst possible scenario,
Right,
I believe
right.
is what people like you who are on the front lines of this have to do.
Right. And I
Um,
think to add to that before you go on, I also think that that is where clinicians in residential treatment get stuck in assessment. And that was kind of the driving force behind my presentation is oftentimes clients will voice their suicidality in treatment and then a therapist or a staff will go straight to hospitalization. But them saying it is the treatment. That's how we get to the bottom of it. So it's really about our own comfort or discomfort with talking about suicide. They're comfortable talking about it, or else they wouldn't bring it up.
and that makes that's actually a really good point. That just by getting it out, they are beginning the process of. I mean, they're seeking help,
Yeah.
and yeah, that's a really good point. Um, this goes back a ways. This data goes back a ways, but the treatment for adolescents with depression study, TADS, it's called. They were looking at comparing monotherapies or therapies that are done alone, one thing
Mm-hmm.
done, and they found a higher incidence of suicidality in cases where fluoxetine, which we all know is Prozac, um, alone was used for treatment, about 14% suicidality. However, when cognitive behavioral therapy was added to the medication, something we're very good at and very adept at, when CBT is added to the medication, they saw the suicidality kind of drop to around 8%. And I imagine that, that data might still hold today. It wasn't that long ago. But clearly adding cognitive behavioral therapy to the fluoxetine, you know, attenuated the suicidality, kind of dropped it down. What, in your life of a therapist, of an LMFT, what do you think it is about CBT, cognitive behavioral therapy, that has that effect to bring down thoughts and actions associated with suicide?
I mean, I think the nice thing about CBT is that it's really structured. It's really easy to understand and use. I think medication can be great, but it doesn't help the person get to the core of the understanding. And adolescents specifically benefit so much from just understanding why. Sometimes they don't know why they feel this way, and then that leads to hopeless feelings. So the CBT or DBT or any type of, modality that we might use in our treatment it's evidence-based. It has a step-by-step process. It helps you anticipate the behavior, anticipate the trigger, challenge some of your negative thoughts. It really puts your mind to work rather than just taking a medication and letting your body feel different. Um, that's great, but then one day, if you don't take your medication anymore, you still don't have tools to take care of the feelings. So the toolbox is what's going to help long term.
Excellent. Well, on that same kind of subject, you work in concert with our team of full time on campus psychiatrists. There's a
Yes.
psychiatrist who's assigned to your girls' mental health program in Penngrove. Talk about the relationship you have with the psychiatrist, how you work together on a daily basis. Because I imagine you're like really tight and in lockstep with each other. And so talk about that a little bit, and then talk about your take on the role of medication in treatment, which I think you just did, but
A little
let
bit
you
more.
go out that.
Yeah, I mean, I would say first and foremost, we're a clinically based program, right? And so there are the medically based ones where you have your primary psychiatrist mainly doing the therapy and the medication management. But at Muir, our clinical team really drives the treatment, and our psychiatrists are incredible. They are very team oriented. They come to every treatment team meeting every single week when we talk about our clients and talk about their treatment plans and what might be coming up that week. And if you were to sit in or be a fly on the wall in our treatment program, you would really see our psychiatrists observing what we're saying. Our psychiatrists listening to what's working and not working. Are any of the symptoms that are coming up that week possibly from the medication change that may have happened? Yes, there are the moments where they present the client and talk about the medication history, but you really see the change in their prescribing or their medication management based on how they're presenting clinically. Um, and that's kind of awesome. I would say like they really take what we say and use it to the treatment of the client. You don't see that a lot. You see a lot of times the medical team kind of drives the treatment and then the clinical team kind of follows and does the therapy, but that's just not how we do it here. Our psychiatrists are wonderful. Um, they're even really family oriented. They talk to the parents all the time. They don't do anything obviously without the parents' consent, but they really help them understand because treating adolescents medically is often really difficult for parents. There's the parents that have stigmas about medication, and rightfully so. Maybe they have addiction in their family, or maybe they had a bad experience with medication. Our psychiatrists are gentle and patient, and they walk through it. The family doesn't feel like that's what they want at that time. They don't push. They just help educate, and I think that's a big factor in adolescent treatment is the education for the parents and the clients.
Great, thank you. Uh, in my own life, in my own personal life, and I've been around a little bit, you could tell from the color of my hair. Um, but I have not one, but four friends
Mm.
who have lost teens to suicide. You know, it's something I can't even wrap my head around. And I'm from a family that lost a child to a traumatic accident, but that is like it's a whole other beast. And as a dad, two daughters in their 20s, I think about it more than I probably want to. Um, so for mom and dad at home, possibly watching this, and we hope they will. What advice do you have for parents? What should they be looking for? What should they be listening for? And if they do, discover that their teen is having suicidal ideation or worse, what should they do? What are the steps they should take, and when should they take them?
I, well, first of all, thanks for sharing your own personal experience. And I mean, that's not easy to be on the outside and experiencing your friends losing children or losing family members of your own. So, in my presentation at the conference, I put up a slide of someone that I lost recently and just talked about that being a big part of why I feel so driven to talk about suicidality, so I can understand that. But what I would say to parents is ask questions. Yes, look and listen, but also talk and be curious. Seek to understand. A lot of parents and individuals and even clinicians are kind of scared to ask the direct questions. Like, what stopped you from killing yourself when you were feeling suicidal? That question is so controversial because some people are like, well, I don't want to ask them what stopped them, because what if they say, well, I don't know, and then they go do it? But if a client or a human can identify what stopped them from following through with their suicidal ideation, that is like a little aspect of hope that they identified before following through with a plan that they might have had. And that is what you can work with. Um, I also would say, for teenagers specifically, look at their hygiene, look at their motivation. If they're not taking care of their basic needs and they're sleeping a lot or not sleeping at all, or they're feeling hopeless and they're making really grandiose statements about everything and always, those are red flags for me. Having a hard time really identifying any hope at all is a big piece. And if you do come to find that your teen is suicidal or experiencing suicidal ideation, ask for help. Depending on the urgency, that's what you first have to assess. If it's like an imminent risk and you don't even feel like you could leave the house, then you would call your local crisis team or 911 or the local sheriff. If it's something that they're having ideation about, but they don't have a plan or they don't have intent, schedule a session with a therapist. If they don't have any therapists, schedule an assessment at a local PHP or IOP, because they will have the assessment happen soon. And then if they feel like your child needs to go to the hospital, they'll recommend that. But if your child doesn't feel like they can stay safe at home, definitely call for help and definitely look for your local psychiatric hospital or local emergency room, because the emergency room will then transfer you to the local psychiatric hospital.
Thanks, Jess.
Yeah.
Jess Mahn is a licensed marriage and family therapist. She's the clinical director at Muirwood's Teen Girls Primary Mental Health Program in Penngrove, California. Jess, thanks so much for joining us, and let's do it again.
Yes, anytime. Thanks for having me.
My pleasure. Take good care.
Thank you.